Welcome to another episode of Myth Busting here in the 5-minute check-in. Very excited today. We're going to do something a little bit different. We're going to take a look at an acute care setting question, in particular the use of PRN treatment for hypertension while in acute setting. And I have two experts with me today. We have Dr. Thomas Frederickson here, who is the Vice President for Hospital Medicine here at CommonSpirit Health, and also an assistant professor at Creighton University. And as always, Dr. Ankita Sagar with us, who is the vice president for clinical standards and an associate professor at Creighton University. Thank you both for joining me.
Great to be here.
Great to be here.
So let's jump right in. Now, Tom, you had a case that, kind of brought the question to mind. You want to present that case to us?
Certainly. I think it's a very common case that we face as hospitalists all the time. It's a 72-year-old gentleman, Mr. Garcia, who is admitted for an elective lumbar fusion. He has hypertension, and at a baseline, his blood pressure is well controlled. And his first couple of days in the hospital, his blood pressure medications have been restarted, and his blood pressure maintains good control. But on postoperative day 2, you get a phone call from the nurse. Systolics are elevated in the 170 range. Diastolics elevated in the 95 range. The nurse is concerned, the intern's concerned. So now we have to decide what to do.
The old what to do. They must call the attending, right? So Ankita, how do we shape this question up for a myth to be busted or not busted?
Yeah, so our myth today is PRN blood pressure control for patients who are admitted to the hospital or in the ER is very important.
So, Tom, I'm assuming you must have a couple of studies we can discuss to discuss the evidence base for this PRN hypertension management.
Certainly, I'd love to, Tom. The first study I'd like to talk about was by Mohandas and his colleagues, and it was published in Hypertension in 21. It's a propensity match study with over 8,000 patients, but it demonstrated a concerning association between PRN antihypertensive medications and hospitalized patients. Some of the adverse events included ischemic strokes, abrupt drops in blood pressure, acute kidney injury, and increased mortality, a longer length of stay. Now, it didn't prove causality, just association because of the design of the study, but in spite of that, it really did provide some evidence that we should be thinking hard about the use of PRN medications in this patient population.
Yeah. Ankita, I'm sure this rings true to you and in your clinical work.
100%. And I think the follow-up to say, hey, this is actually associated to that abrupt drop, I think is the key piece of this study. So that's scary, for sure.
Scary stuff. And Tom, very quickly, the second study, I think that was more on the discharge side of things, right?
Yeah, it is. Of course, there's always the concern, what do we do at discharge when this patient has an elevated blood pressure? Well, I'd like to share another study by Anderson and colleagues. It was in JAMA Internal Medicine in 2019, and it demonstrated the risk of intensifying antihypertensive regimens at hospital discharge for older adults. It showed increased readmissions, increased adverse events, including cardiovascular events. In fact, the number needed to harm in this study was only 27, and it didn't show improved blood pressure control on an outpatient basis.
Right. So that's a low number, which is a bad number, right, Ankita?
Absolutely. I mean, 27 is a very, very low number needed to harm. So this is, to me, very striking as a study to use for best practice.
All right. So it sounds like we should be a little cautious about PRN blood pressure lowering in the acute setting. So what are we going to do? I mean, let's give us some quick options here, Tom.
Certainly. Fortunately, there's a lot we can and should be doing. Of course, we always need to assess for end organ damage. If they have that, then we treat appropriately. We need to ensure proper measurement. We all know how to do this. Recheck the blood pressure, make sure the cuff size is right, make sure the patient is relaxed and in the right position. Next, we need to look at other factors. Consider pain, nausea, anxiety, hypervolemia, drug alcohol withdrawal, urinary retention, and there are others. This next one is often forgotten. We need to ensure the home medications have been restarted unless they've been contraindicated. Next, look at the med list. See if the patient's on offending medications, such as steroids or nonsteroidals, stimulants, decongestants, and don't forget erythropoietin. Next, we always need to ensure a good, warm handoff to the PCP, so the PCP can address this issue in a longitudinal fashion.
Well, this is the answer to a lot of problems. If we could do a warm handoff, I think is critically important. So I as a primary care provider myself, I know how important this is. So Ankita, I think you have to ask the question now.
I do, and I'm excited to ask you, is PRN hypertension management an important consideration? Is that a myth or is that not?
Well, Tom and Ankita, I think we can safely say this myth has been busted.
I think you can safely say that. Well, thank you both for joining me in this episode of Myth Busting. It was very informative.